am really delighted to introduce now Julie Rovner, who is going to moderate our next panel on delivery system reform and the healthcare workforce. So continuing on Polly's remarks, and Julie is senior health correspondent at Kaiser Health News and is going to introduce our next panel. Julie, thank you. And if the next panel, you guys should all be ready to go. Come on up. Thank you.
Good morning. Good morning. I do still need my glasses. Thank you all for being here. I am honored to be here with this amazing panel to discuss delivery system reform and its effect on the healthcare workforce. I think Polly gave us some good things to think about as we go forward. As Sarah said, I'm Julie Rovner. I'm Chief Washington Correspondent at Kaiser Health News. And before, about a year ago this week, I was spending most of my professional time looking at health workforce issues. So it's nice to dip back into it, at least temporarily. I'm still hoping that if things settle down, I can go back to what I was doing before being interrupted by a new round of efforts by the federal government to remake the healthcare system. I'm joined today by some really impressive health workforce experts. I'm kind of geeking out here. We're going to spend the next 45 minutes talking about the intended and maybe some unintended impacts on healthcare providers of efforts to improve the delivery system. I'm going to interview these fine people for about a half an hour, then you will get your turn to ask questions. So without further ado, here are our panelists. You have their full bios in the handout, so this will be the Cliff Notes version. Ann Greiner, who's in the middle, is President and Chief Executive Officer of the Patient-Centered Primary Care Coalition, which is working to advance an effective and efficient health system built on a strong foundation of primary care and the patient-centered medical home. Thomas Jenike is Family Physician and Senior Vice President and Chief Human Experience Officer for Novant Health, which is an integrated system of physician practices, hospitals, and clinics that serves North and South Carolina, Virginia, and Georgia. And Bob McNellis is Senior Advisor for Primary Care in the Center for Evidence and Practice Improvement at the U.S. Agency for Healthcare Research and Quality. He's trained, practiced, and taught as a physician assistant over his career. So let's get right into it. I want to ask each of you to answer this first question, which is from your perspective, what are the biggest challenges facing the healthcare workforce right now?
So my area of passion and expertise is around physician burnout. So when you ask the question, what's affecting healthcare right now, to me, it's just the rapid degree of change that physician, I'm going to speak from a physician standpoint first because that's what I am, is that we've always had a high degree of change, and it's always been hard to practice medicine. I think in the current climate, the rapid changes have been coming so fast that it's people are starting to lose focus on why they even went into medicine. And I think one of the biggest challenges is people not necessarily quitting healthcare, but staying and quitting at the same time, which I think you know what I mean by that. Mm-hmm. So I think that is a big risk, not only for the physician shortages that we talked about in the first couple presentations, but for quality, safety, and all the like. So I don't think it's good for anyone if the physician themselves or the caregiver isn't taking care of themselves and is feeling burnout. So I think all the degree of changes is really threatening the delivery of healthcare for our communities and for the health of the provider.
Yeah.
I think it's a myriad of factors. I'll just name a couple. This move to value and all that comes with that in terms of the reporting requirements, the regulations, redesigning your practice. I mean, that is all very new territory for health professionals, and that's quite stressful and takes a whole lot of time. I mean, the literature suggests that physicians and other health professionals are having less time with their patients because of really attending to all of these other things. And I think technology, too, is having a huge effect. I mean, EHRs and then all the other technologies that are really beginning to become a part of practice.
Thanks, Julie. It's a pleasure to be with all of you today. At the risk of being redundant, I'm going to sort of take a slightly different perspective on this. And I give a lot of talks, especially to students or professionals. And I have this slide that I show, healthcare at a crossroads. And it turns out that actually the talk that that title talk was given in 1988 by Uwe Reinhardt at George Washington University. He talked about healthcare at a crossroads. So what are we today? We're healthcare at a crossroads. I mean, you can use that every year for the last 30 years, right? And so if you take the long view on it, there's nothing new. I mean, there is lots of things new. It's the rapidity of change that's happened over the last 10 years for sure. Probably the last 5 years, I think that has really put people off balance. And that's where it's at. But we've worked on this through other administrations have worked through health reform. I think the IOM report in 99 and 2000, those two reports changed the way we think about healthcare.
Medical error reports.
Exactly right. Actually, National Academy of Medicine now. Right. But I'm thinking Crossing the Chasm to Err is Human. And the response to those two reports in particular have changed the way we think about healthcare and put things into place very quickly without actually, maybe we didn't sort of see far enough what some of those unintended consequences might be.
Well, I want to dig down into this a little bit, and let's talk about how delivery system reform, new models of care. I mean, as you mentioned, things have changed really rapidly that are being experienced by the healthcare workforce are really changing how they do their work. And I'm talking, yes, physicians, but everybody along the spectrum of healthcare delivery. How is the rapid change impacting people? Anne, why don't you start?
Well, funny that you should mention the IOM reports, because when I was at the Institute of Medicine, now the National Academies, I worked on a report about health professions education and what are the competencies needed for healthcare delivered, in the vision of the quality chasm. And a lot of the competencies are the same, except for there are two that are novel that I think really suggest that there really has been this evolution. And that report came out in 2003. The two that are new are, that I think are really competencies that health professionals need are a focus on value and talking about costs of care. And, this is a whole new territory, but if we're really going to get to, the value that we all expect from our spend, we've got to deal with costs of care. And there's some great new resources that are coming online to help health professionals do that. And I think the other competency is really dealing with the social determinants of health. Because now we know, we didn't know then, how much that really contributes to patients' outcomes. And so, how do we teach those competencies in our health professions education? Not really. So we're not really helping professionals to prepare for a world where they're going to have to understand how do we address the social determinants of health? And that's a big, big question.
And I want to talk about training in particular in a few minutes. But right now, I want to sort of zero in on how professionals are experiencing the rapid change.
Sure.
And what does this mean on the ground to members of the entire healthcare team?
Well, I think they're pretty stressed. I mean, you do so much research on burnout, and they know they're not really able to meet their patient needs. They are spending a whole lot of time with entering data, either in the electronic health record or to report all the quality measures that they need to report. And they're less satisfied. And I think we see it in turnover rates. I think we see it in burnout and workforce and it's not just doctors, it's nurses, it's pharmacists, it's across the gambit. And when they don't feel, able to really give their best selves, both their clinical skills, but also their emotional skills. I mean, that's such a big part of caring. If you're depressed and you've got a lot of anxiety and you're not able to show up, that really has an effect on patient outcomes. And there's more and more research that's showing that.
That's true.
Yeah, so from my perspective, I think the single biggest shift that's changed the way that people deliver care on a daily basis is the electronic health record. I think that early on we talked about how we're going to pay for it, how we're going to put it in, how we're going to all be connected. I think what we really missed was how it was going to change the day-to-day workflow of everyone on the team. And the literally hours of additional time that everyone, including providers, take at data entry, quality metrics, and then getting nurses to start to assume some of those roles too. So their roles have completely changed. They went from talking on the telephone to instant messaging patients. So everything has changed in the way that we care for people. And that has been, I think, overlooked. And I think it is one of the biggest things that's driving burnout and driving dissatisfaction and taking people away from the core of why they chose to go into healthcare.
Do you have something to add?
Yeah, sure. And at the risk of being an advertisement for ARC, I'll just say Agency for Healthcare Research is a small research agency of the federal government. Small number of employees, but we do research on what works in health services research in particular. And we've done some research on burnout, we recognize it's a big problem, but there are some solutions to it as well. I can also say that EHRs have been a problem. We also have a large research project in small primary care practices called Evidence Now. 1,500 small primary care practices understand what they're seeing. We see pretty high levels of burnout, about 25% in physicians, 20% in NPs, PAs, and some of the nurses working in those areas. But you know what? And EHRs can be targeted as some of the problem because it's hard to get data in and really hard to get data out. But you know what? When they work, they can work really well. And we've done some work to help people make them work. And all of a sudden, things go away. We see practices that are excelling in the care they deliver. They feel much better. They're getting data about how well they're doing. The trick is to getting them work. And that takes actually some things that we're going to talk about later about teams and outside and inside the practice to get that to work. So I think there are some solutions. Even though people are feeling the stress, I actually see some hope at the end that if we get this stuff to work, people will be a lot better off.
You've anticipated my next question, which is obviously we're focusing here on problems because we're trying to solve problems. But I mean, what are the things that technology has sort of in the changing healthcare delivery system has done that actually are making lives better, both for patients and for providers? You were already talking about it.
Well, great, thanks. For providers, I mean, imagine a place where actually you could imagine, and this may take a little imagination, where it's actually easy to get data into the EHR. And there are some techniques out there, scribes, people who are dedicated to that, allowing the clinicians to really focus on the patient. And then you can have meetings with your team to bring them together to see how well you're doing on delivery of important care processes. And then you can work through solutions on how to do that better. And there's some intellectual joy to actually sort of solving those kinds of problems. I mean, that's what healthcare providers were trained to do, is solve problems in patients. We can help solve problems in practices by providing some of these external supports for them as well.
Oh, you guys have been working on this, yes?
Yeah. So I think for what can really work with electronic health record, and I don't mean to demonize it because there's no going back. So we get that.
And I'm not just talking about the electronic health record, by the way, although that does seem to be where everybody's frustrations end up lying.
Yeah, so from the electronic health record perspective, for a physician, it can start to give us better insight on how to take care of patients. You know, for decades, for centuries, I could be practicing alongside a partner. I could be treating someone in a certain way and think I'm doing an awesome job. Mm-hmm. And now we have data that's out there that can say, okay, well, this is actually the best way to take care of patients. Mm-hmm. So if you can actually harness it in a way that is easy to get to and say that this is the best way to take care of this patient with this problem, and you don't necessarily have to use the art of medicine so much when it comes to diagnosis, it really can be helpful. And from a patient's perspective, we know that consumerism is a big deal. We know that the new generation of people getting health care want to get it through a handheld device. So it is going to be easier for them if we can get it to work. So I really think that things can be better for everybody.
Yeah, what's good? What's good about delivery reform?
I think in systems where the HIT is working well, it can help really to facilitate team-based care, because you're really helping everybody on the care team to get the information they need to take care of the patient in front of them. And, you know, who's on first will depend upon what that patient's need is, and, you know, who's delivering the care. That will all, you know, is constantly shifting, particularly in primary care. So I think there are, you know, bright spots where that is really working well, and people are seeing the promise of technology to help with care integration and communication and really what's best for the patient.
Yeah, and if I could I'm sorry, Julie, just to bring the patient's voice into it as well.
Which was my next question, so go ahead.
Anticipated.
You're doing really well.
Yeah, well, it's just, I mean, I saw my primary care doc recently, and I had my lab results, and I could pull them up online. You know, in a paper-based world, it's really hard to do that. And I think that decreases their load as well. So there are opportunities for patients to be more engaged in their care they're getting, I think, through the use of technology. There are other things around delivery system reform that I think are positives. In addition to the EHR, the potential for the EHR is population health, focus on populations. I mean, I often say that we're not going to get to the kind of quality we want in this country one patient at a time. We have to think about groups of patients and groups of people in communities. And having that kind of data around communities really helps you manage your entire population, not just the patient in front of you at the moment. So I think there's a tremendous opportunity there as well for some of these things.
What is it? So how is the patient experiencing delivery system reform? I know, for most patients, it's just there's now a computer between you and your practitioner. Sometimes the doctor, sometimes the NP, or PA. Or as you said, there are now opportunities. Although, speaking for the end of one, every doctor I go to has a different patient portal. I mean, I can't. And you sign up for it, you can't remember the passwords. I mean, and literally every single system is different, and that which is not. So I get the feeling that there's a lot of that patients aren't seeing a lot of the good that's supposedly going on in improving the healthcare system, and I assume that then reverberates back on providers and probably not in a good way.
Yeah. So from my perspective, I think patients see more of the upside than the healthcare providing team. I think they see an increased transparency, the fact that you can see your health record, that you can get your labs in a timely manner. I think the fact that they can do online scheduling, they can do video visits, e-visits. I think most of the things have been beneficial for patient care, for patients. So I think that patients, if you ask them, they say, this is going the way we would like it to go, from my perspective. I think it is patient-centered. It just wasn't really thought through on how it was going to impact the whole team.
Yeah. And how's it going in the primary care world?
I think it depends. We're in a messy period. There's a lot of change happening, and there is certainly practices, as you described, where you can do an e-visit. I can email my doc. I can, jump on and get a televisit at 10 o'clock at night if I wish. Lots of other places that's not occurring, and so. I think so much is dependent on the market you're in and the practice you're able to go to. I think also all that's happening in the insurance market has an effect on patients, because when you're in a high deductible health plan and you have a very large deductible to meet, you just may not be taking advantage of the primary care services you need for health promotion and prevention, even chronic disease management. And so that also factors in here. You can't, disentangle that environment has an effect on patients as well, and as we're all moving to value-based payments. So, what's going on in the insurance markets has a profound effect.
I want to talk a little bit more specifically about burnout among physicians, burnout among the entire, caregiving team. You're working on this particularly. Obviously, we're in a trying time. Although, as we've heard, it's always been a trying time in healthcare. Healthcare is at a crossroads all of the time. But this does seem to be a time of particular asking people to do more with less, or asking people to do things in a very different way than they were perhaps trained for. How, in this very sort of churning situation, do you work to make the caregivers resilient, as I think is the word you like to use?
Yeah, so, I think when, it might have been Glenn this morning talked about the triple aim, I think the quadruple aim is having the healthcare providers find joy in practice. And for me, the way we think about this, we have a position on burnout, and we don't feel like we need to do much more research. We know it's there. So we really want to start tackling the problem. And the way that we're looking at burnout is that there is a whole bunch of external forces and factors that affect the healthcare team, and much of which we've talked about today. And we believe there's a whole bunch of internal factors inside the provider that also can lead to burnout. So what we have taken the approach on over the last 5 years, over thousands of physicians, is to really address what's going on inside of you, because we're going to confront and admit that the changes are not going to stop happening. So if we're just going to try to damp down the changes in hopes that it makes you feel a little bit better, we know the next change is going to happen. So that our approach is to work from what I'll call the inside out, and have people have a degree of awareness of their patterns around all these changes. What is that making them feel? How is it making them experience their work? And understand that this hamster wheel that we feel like we're on a lot, that in some cases, as the physician, I'm the one turning the wheel. Like, I literally am the one turning the wheel because I have this success model where I have to be the best. I can never make a mistake. I'm a perfectionist. And all this comes from my training, and this was what allowed me to be successful. So we want people to stop and look at what is their contribution to their own burnout. And you would think that that would be met with a lot of resistance and hostility and, oh, you're blaming me. But what we find is that people feel a new sense of meaning. They can reconnect to why they went into healthcare. They can now find things that recharge them and restore them outside of the healthcare world. And we're building communities of physicians who are looking out for each other. All this in service of them being more resilient so that they can go into a high-pressured environment every day, which we know it's going to be, and give their best, and then go home and give their best to their lives. And that's what, for us, has really been transformational. And once we've done that, they have been much more willing to stop becoming the victims of this medical machine, but to be an active participant in trying to diminish some of those external forces. So we've seen tremendous success over the last 5 years by using that approach, starting with the individual and then working around it rather than just trying to dampen down some of those external forces.
Is this just for physicians?
No, we started with physicians, moved on to our advanced practicing clinicians, and this year we had the same type of program for over 900 bedside nurses with amazing results, and which I can share if you want to at some point.
Are they less perfect? They're making them give up perfectionism?
They are what we invite them to do is to choose to not always be in perfection mode. Like, there's times if my...
I mean, from a patient's point of view, I'm not sure I'm down with this whole thing.
Yeah, exactly.
You're asking my practitioners to not be perfect.
What we're asking them to be is versatile. So if I have to have a neurosurgeon see me, I want them to be perfect. However, if they're going to go on vacation with their family, they don't need to be so perfect. They don't need to take the same model that works in their professional life and apply it to everything in their life, which is what we often do as human beings. As we do some things, we do all things. So as a provider, we like to be in control, we like to be independent, and we find that that's a big barrier to finding joy in life. Because if you're locked into that, I could have my feet in the sand at some awesome beach, and in my head, I can still be grinding on work back home. We're asking them to be more versatile.
Yeah.
You know, I've been struck in working with physicians over the years how much responsibility and ownership they take on for everything. So if something's not right in the practice or on the hospital ward, it is their fault, and they've got to fix it, and they've got to rescue it. And when you start to do some of the work, and I've worked some with IHI, where it's like, no, we're actually going to solve these problems together as a team. And, oh, by the way, we're going to invite patients and families in to help us figure out, how we might change delivery to make it work better for everybody. And they begin to see that it's not just you, doc's responsibility to solve it all for everybody. And I know it's the way you've been trained. It really does help to lessen that burden, because we all want change in the system, and that means we've got to do this collectively, and it's no one person's job. And I think that, I was heartened to hear your remarks, because I think it really can help when people feel like they're not in it alone.
Yeah, and I think you're right. I think team-based care is the way out, and oftentimes the barrier to that is the physician. Even though it's the best thing for them, they have a mindset of control. So just having them see that, to your point, it doesn't have to be you. They have to grapple with that a little bit, because it's been like that for so long. So it's a mindset shift that we are in this together, and when you can do that, it does take the burden off.
Yeah, and I can't say, Tom, what you shared was wonderful, and I value, the perspective from that. But I definitely agree that team-based care has some great opportunities with it. Personally, I've worked on some great teams, and it's been when I've been most fulfilled in my life is working on great teams. They weren't always in healthcare. Sometimes they were in other areas, but I've definitely seen it work in healthcare as well. The challenge is that you're right, some people don't know how to work on teams. And all I can say is there's some good stuff, and ARC advertisement, there's something called Team Steps, which is a program that we put together sort of mostly in response to patient safety issues, but now we've expanded it into ambulatory care and primary care settings to help train people up about how to do it, how can you work best. And it's really about relationship building is what Teams is, and good communication. And if you can just bring about relationship-centered care, whether it's with the patient or their team members, and about having good communication, that goes a long way towards building the kind of teams that, where you need trust and accountability. Everybody on the team needs to be accountable. We can share. I share your pain, Tom, and we'll do it together. Those kinds of things I think can go a long way.
Agreed.
So let's talk about, team-based care and training the next generation. Obviously, one of the difficulties and one of the reasons we have so much burnout is that so much has changed so fast, and people who were trained, many years ago or even a few years ago, are having to completely overhaul their, the way they were trained and their mindset. So how do we, now that we sort of know and understand that the generation that's being trained today in health professions is not going to practice in the system as it is now. They're going to practice in the system that's changed in ways that we don't even necessarily know. So given that, how do we adapt training programs to help practitioners be more, I guess, adaptable to change? Is sort of the key here, right?
You feel free. I'm not trying to answer.
I think it's a really big and challenging question. And any place in the healthcare system, I think the education system has been the most allergic to change. It really has been. And so lots of change going on in delivery, not as much change going on in education and training. And unfortunately, they're kind of in separate orbits. Even though CMS oversees in terms of Medicare payment both, but they operate very, very separately. And so there needs to be much more integration so that care delivery is really informing what we need to do with respect to education and training. Education and training should have the triple aim as their goal, and that's what they should be thinking about. How do we train? We should be training for the quadruple aim. Excuse me, the quadruple aim. So I think that's at the that's at the highest level. I mean, still health professionals by and large, and there are bright lights out there, and the new Kaiser Permanente school and University of Florida and Colorado and Oklahoma, lots of bright lights, but by and large health professionals are trained in their silo, and then we ask them to go work in a team. Well, they don't know how to work in a team. They don't know the first thing about what are your competencies, what do you bring to the table. So we've got a ways to go, Julie.
And I can talk just briefly, Tom. So I worked at George Washington University many years ago, and I worked in the PA program and taught a variety of health professionals. But here's what didn't work: is we'd throw all of them into the same classroom for a couple of courses. So the PAs were there, the NPs were there, the docs were all there, all listening to this material. Having people sit in the same room together is not encourage team-based care. Might be good for happy hour, but it wasn't great for team-based care. What does work is there's some great movements around interprofessional education now that's certainly been happening over the last roughly 10 years or so, where they're starting to see what are those core competencies that we share across professions. How can we understand better what each are doing? I think there's some real efforts to really move in that direction. I think one way they did it at some institutions is by getting them to work in a student-run clinic together, and then you can see how that all plays out in shared responsibilities. And in places where that's been done, people have much better recognition. Okay, here's how I work with the pharmacist. Here's where I work with the behavioral health person. Here's how the medical assistant can help me do my work better. And that's really been, I think, has tremendous value. And we just need to sort of expand those kinds of efforts, I think, to some degree.
I think those are expanded. I did a story on this last year. I was at Case Western, and actually one of the things I did was sit at one of these workshops where, they do have a student-run clinic, but there were medical student, dental student, pharmacy student, social work student, nursing student, all sitting around a table, and they gave them, some cases, and they actually talked through what they could do. And it was interesting because I could see the students, but I didn't know who was who. And at the end, I was trying to figure out which student was which, and I was completely wrong.
Interesting.
Well, that's a good thing, right?
Yeah, no, I considered that a good thing.
Yeah, I think from my perspective, you have to go back to the beginning of the training, and I think it may be individual institutions or it may be some sort of government thing, but someone needs to put a flag in the ground for this is the way we are going to practice medicine in the future. we can, the days where we practice in silos, practice independently, those days are over. And understand the why behind that, because it's better for you as a healthcare provider, it's better for the patients, it's where our healthcare is going. So someone has to put a flag in the ground and say, this is the way we're going to start training people. And I don't know who has the clout to do that, the courage to do that, and it may come in pockets like the organizations you said.
Well, think about the federal investment in graduate education. I mean, that's what, 12 billion? Is that right?
Something like that.
So it's a lot of money.
That's power.
Yeah.
Although the National Academy of Medicine tried to take a whack at it and immediately got smacked down. So there are a lot of entrenched interests, I guess, and that which leads me to my next question. What's the thing that's been left out of healthcare delivery system reform that, from a provider point of view, really needs to be included? I mean, what aren't we doing that we should be doing more of, or what are we doing that we should maybe be doing less of?
Yeah. So I guess trying to think about the learnings I've had over the last couple of years, one of the things that seems to be lacking and can certainly be enhanced is having physicians understand that they are leaders. So, and they are a leader, whether they have a formal role or an informal role, every space they step into, they are a leader. Every healthcare professional, for that matter, is a leader. So leadership training, starting with how can you lead your own life, how can you influence a team, how can you work well as a team, and then how can you influence a broader spectrum, whether it be your healthcare system, your society. So I think investment into communication, self-awareness, team, how to function as a team, and understand that you walking into every room, whether it be a patient room, an operating room, your living room, is never a neutral event. And I think having practitioners understand that and be trained in that will go a long way to help us to increase resiliency, decrease burnout, and increase teamwork.
I think there's a whole lot of competencies that we need to teach, but I think in general we focused on delivery and payment as the two big buckets, and we haven't spent enough time thinking about the workforce, which is why I know we're having this panel, and it's a great discussion. It seems to me that one of the key competencies that we still, by and large, correct me if I'm wrong, but I don't believe our teaching is really quality improvement science. And so, practitioners are getting back, this data, and they desperately want to improve their, change their delivery system so they can improve in a value-based world, but they don't know how to go about doing it. They need a whole lot of training and support. And that is the kind of activity that is generative. It's a wonderful vicious circle. If you're getting trained on something to improve the system, and then you're improving the system, and then you're able to do better in a value-based world, well, that's a win-win for everybody. So all of these competencies related to team-based care and patient and family engagement, and how to use technology better, and costs of care, those are all really important. But I see the quality improvement science as really, just a crucial piece of what we need to do to help health professionals really be prepared for this new world we're in.
Is that a role for Art?
Yeah, we're a research agency. I'm happy to fund research along those lines. But what I will say is, just to pick up on what Tom and Ann said, is I agree with the leadership and quality improvement science, and I think hand in hand with the leadership part is a culture, and building that culture that you care about quality improvement, that is integral to what part of your mission is. And there have been efforts by the feds and others to do that. CPC, the Comprehensive Primary Care Program, Transforming Primary Care initiative. I mean, those things are all really try to help practices move in that direction. Some of the work that we've done around building quality improvement. But what we need to do is there actually needs to be some resources from outside to help people get that, because you can't teach everything in medical school or PA school or nursing school. A lot of this is stuff you have to learn after you're out there working, and having some resources to bear on that, I think, can have great effect. And that's probably where we need to invest some money as well.
So I've been doing this for 30 years, terrifying sometimes. And obviously, one of the continuing, I love the sort of the Uwe Reinhardt, we're always at a crossroads. We're having yet again a national debate over the role of the federal government in healthcare, which is, we're a little bit pregnant on that front at the moment. It would be very hard to back the federal government out of its role in healthcare. But there's also all of these competing, power centers and I think that's one of the reasons that healthcare sort of tends to grow as it grows. There's nobody with a hand on the rudder because there's everybody fighting to put their hand on the rudder. So is there a way to, everybody, if you actually sat everybody down and said, quality improvement, having the right workforce are obviously some of the keys to having a functioning healthcare system. Is there a convening authority place way to do this where people could actually sit down and discuss this that didn't, so we can get over this sort of hand-to-hand combat?
So here we are, Julie.
No, I can just sit here.
These are the folks who need to, control that destiny to some degree. Certainly the federal government has some role in that. I mean, as one of the largest payers, I've heard it described as an insurance company with an army. There are lots of drivers there as well. And, as we've talked about, administrations will come and go, policy will change. Healthcare will need to be provided to people. Disease, death, and disability are not going away anytime soon. So one way or another, I think we'll work through this. What did they say? That Americans will try every possible event until they find the one that ultimately works. But I don't know. We don't have yet that kind of body to do that. And I was reflecting on the way over here that once upon a time there was an idea to put together a commission to think about deliberate health workforce, what it should look like, where it should be, and that didn't go anywhere either. Right. So I think we're going to continue.
There have been so many of those.
There have, and we'll continue to wrestle with that, but that's our way, perhaps.
Yeah?
Well, I mean, I think the Uber is we got to change payment because if we were actually incenting for patient outcomes and for reduced costs and for better health of the population and joy of the health professionals, it would be a very different delivery system. So. Waving that big magic wand, that's a big one. But I also think, at the micro level, the food fights don't happen as much or as vigorously when you have patients and families in the room.
Yeah, that's a great point.
And, because then the focus is on what are we doing to improve care for that patient. And it's embarrassing to, have the fights about who does what and all of that. And so I think that is a really important and transformative lever, and I appreciate that CMS and the private sector and, increasingly, you look, this is really a growing movement, not just in acute care settings, but also now moving into primary care and all kinds of settings to really bring that patient voice in. And, we're in early days on this. We've lots to learn about how to do that successfully, but I think it can be transformative.
So I have no idea what the body is, but I agree.
That's why I asked.
But I agree with Anna.
Could there be such a body?
And I think this probably has to be driven by healthcare professionals themselves, rather than people that are just making policy. And I do believe, I agree totally with you that I think until we address the reimbursement, that it is contradictory to what we are still, right now, I'm getting reimbursed in a way that is not, is incongruent with what we're telling people that's important. That's just a mismatch, and it creates a lot of mixed signals, it creates a lot of mixed emotions and motives. So until we get that, I don't think we're going to be able to be aligned. And my sense is that it's going to have to come from the consumers of healthcare and the delivers of them, rather than just people that are writing laws. That's just my sense.
And maybe there is a role for ARC here, just say, because we've done a little bit of work on what kind of workforce do you need, what is the composition of people you need in primary care, and how much do you need to pay them to go? And we've started to model that a little bit, and we're still tweaking it, and we'll get it out there. But in a primary care practice that serves 10,000 adults actively, if you have sort of roughly 8 clinicians of various sorts, physicians and NPs and PAs and a variety of other health professionals to provide comprehensive, high-quality care at about, I think we calculate about $45 a month will build you a team that can deliver high-quality care. And if we're not paying that much per month per patient in that panel, we're not paying enough to get high-quality, comprehensive care. And I think we'll do a lot of work to tweak that, but that's the kind of work that might need to be done to figure out what is a rational payment policy for some of the things that we're hoping to get out of healthcare.
For someone who's ready to create a rational payment policy. I'm going to open it up to the audience, and is there a microphone? That's over here. I'll get to you next. There was somebody with a hand up over here. And please tell us who you are.
Sure. Rick Blake, the Institute for Family Health in New York, and by extension, the Icahn School of Medicine. 68% of our 800,000 patient visits are Medicaid. And we are extremely, the first speaker in the panel spoke to the issues of payment and burnout and stress. But on the other hand, most of our doctors and residents are committed because of who we are and the kind of patient population we serve. So the payment issues related, right now in Congress, I think, Ms. Rovner, you related to them, are pitting family health centers against dish hospitals for the payment reduction. So we're bundled into the CHIP bill. So we actually, in order to preserve the 79 teaching health centers around the nation, the dish hospitals have to, the bill passed, number one, but we are put in a really bad position, and it's not theoretical for us. We're put in a very bad position in terms of retaining residents. We have to pay out $4 million. We have 40 residents, and most of them are residents of color or other ethnicities. It's the highest rate in the country. So we aren't, these issues are not theoretical to federally qualified health centers as large as the Institute for Family Health. So my point is this. Given the current environment, because that is what's shaping us all, frankly, how are we going to resolve not just the issues of physician burnout, but the possibility of rationing health care for those most in need?
Can I just stipulate before you guys answer this that it is curious for Congress to create a residency program with funding that's shorter than a residency?
Curious is a good word.
I don't write the laws.
You're looking at me. Everybody's looking at me. I'm not quite sure where to go with that, except I feel your pain. And you know, I think I spent actually interesting. It's been a meeting week for me. Last week at PCORI, so I heard a lot about the patient voice in research. The last couple of days I spent talking about FQHCs and really how to support them in the work that they do. And I know they are doing God's work. I mean, they're there because they want to be there. But making ends meet and keeping the lights on are important. And I don't have a solution, except that I think it's important to think about that. We haven't talked at all about delivering care in vulnerable populations and what that means, and I think that's really, really important part of the conversation that is getting skipped over as well. So I'm afraid I don't have a solution except to say that folks need to think about that.
Okay, there's a question over here.
Hi, I'm Vivian. I'm a family physician, recently graduated from residency. So I've worked both in underserved settings as well as in private clinic settings. And I wanted to ask, I know some of you guys alluded to, but if you could address more specifically consumerism and that involvement in healthcare delivery. So there's my job, which is making sure my patients are healthy. And then there are some patients that, you know, rightly so, I demand to have my labs done. I want to know. And I have friends and families. One of them fractured his back jumping off a roof when he was a teenager. And he still has back pain. He's like, I want an x-ray just to know what it looks like. And some people, they have a headache. I want an MRI just to know what it looks like. And I don't know how to say no. I mean, I get that, you know, but also I don't think that's the best care. But then there's also this consumerism aspect, and part of me says, if you can pay $50 million, you know, go ahead and do that. So how do you guys meet those things.
There is a great nonprofit called Costs of Care, and they are international. They started here in the U.S. And they
By a medical student.
What'd you say?
Neil Shaw was a medical student when he started it.
Yeah. I mean, he's a great guy. And they're really, really helping health professionals to figure out how to have those cost of care discussions. Because, oh gosh, I'm not sure what changed. Because that is not something that you learned, I imagine, when you went to medical school. And it's tricky. And so they have 3 very basic things. They say that you need to do a screening of all of your patients to understand, where they are financially. And it's just the way you take the any concern about doing that is it's applied to everybody, and you have that information, and so do they have difficulty paying for their drugs? What's their insurance deductible? You have that information. 2, that the clinician actually has some basic knowledge about the treatment modalities and the various costs. So you have some information. And then 3 is that you're customizing a plan. And they have these great vignettes on their website that really helps clinicians to have those kinds of conversations, because each of those conversations obviously then contributes to, are we moving towards value? Are we really, and it's both sides of the equation. It's the decisions that the physicians and other health professionals are making, and it's what patients want. And so Choosing Wisely is a great campaign to help in the education of that. At the Patient-Centered Primary Care Collaborative, we are in the CMMI grant, TCPI, and for years 3 and 4 of that grant, we're going to be integrating Choosing Wisely into the patient and family engagement work that we do to really help on that consumer side of the equation.
Yeah, so from my perspective, these are some of the hardest questions that you have to face day in and day out. I know when I worked in residency, I worked in an underserved population, and then when I worked in private practice, I worked with a more affluent base. So I always kid that when I was in residency, I was always trying to convince people they were sick. And now I'm trying to convince people they are not sick. So it's a really difficult challenge. And I believe that this whole thing of consumerism, we're just getting started. This is not going to U-turn. It's only going to get more powerful. And I think one of the things for us as providers is to not be in resistance of it. Just to understand this is just part of the landscape now. And I think this is not an easy answer, but I think part of it is just based on relationships, communicating, and then having data that we are now going to be able to use to explain to patients, this is the best thing for you. I know it may not be what you exactly agree with, but based on millions of points of data, this is what's best for you and best for your wallet. So, I mean, I think it's just honest conversations, but it takes trust, it takes relationships, it takes time, which of course is harder and harder to do now in this fast-paced environment.
I have little to add, except good for the patient for feeling empowered to ask for something from care. Although I think it's as a negative they're asking for inappropriate things. I think it's good that patients feel empowered to ask, and good for you, for knowing what's appropriate and what's not. And what's left is the conversation to bring those views together. And part of it is a relationship, and it's going to depend on what your situation is. But I think those are 2 powerful forces that need to continue to move: is people asking for things that they need, and then you helping guide them as to what is really helpful and what's not. Those are 2 important things.
Another question back here?
Hi, my name is Tammy Mayo Blake, and I am with HRSA, the Bureau of Health Workforce. And I have a question about the team-based and interprofessional care. A lot of the grants in my division we give to medical schools, schools of allied health, and we are trying to push or urge them to integrate this into their curriculums. And I just wanted to ask what kinds of things your organizations are doing to work with medical schools and schools of allied and behavioral health to help guide them to the idea of training their students in team-based interprofessional care.
Well, I'll just say we don't work directly with medical schools, and actually we look to HRSA for workforce things. We think about workforce as it relates to who do you need to deliver the highest quality care. But what we do create are tools and resources that come out of some of the research that we do. So Tammy, call me and I'll point you in the right direction to whether it's our team-based care stuff or I think we have some good tools. Shared decision making. We have a variety of different things that might be helpful to you, but we don't work directly with them. And if you do, and you're a vehicle to get that out, I'm happy to work with you or anybody here to get those materials out.
Yeah, so for our healthcare system, which is a very big integrated healthcare system, if I think back even 5 years ago, there was a lot of reluctance to do what you're talking about. And a lot of it sat within the physician, to be honest. Like, I can't work in a team like this. I'm in control, I'm responsible. And what we have found over time as we have started to help people understand why they're burning out and them starting to lean in and say, okay, we want to help solve the solution, they're much more amenable to now working with teams. So we now have a number of think tanks within our medical group that are saying, how can we provide the future of primary care? What does that look like? And we've partnered with nursing schools, with advanced practice clinician schools like PA and NP schools, where we now have them as rotating students. So to already start to integrate them, we see this as the way out. So, and now there's a lot less resistance from that because people really understand the why, both from a provider team standpoint and from a patient care standpoint.
Nothing to add. Okay. Maybe one more question. Okay. Right here in the middle.
Hi, I'm Amy York, and I'm with the Elder Care Workforce Alliance. I haven't heard the word aging on this panel yet, and I think it's probably the elephant in the room. And a lot of what you've been talking about is training that's been happening in geriatrics for years, and I'm wondering, can we both train in geriatrics and team care at the same time? Because it's really the entire workforce that's going to need to be trained in geriatrics because of demographics. And what are ways you're seeing this happen? The other piece is too that there are lots of opportunities, I think, in geriatrics for training opportunities for students. Especially the VA is an interesting thing that I think could be really interesting, and that's where a lot of folks have trained in geriatrics. So just a lot of thoughts and wonder where you guys are at on it.
Well, we obviously have such a shortage of geriatricians, and I agree with you. If our policies related to residency slots don't change, I don't think that's going to change. So the notion of everyone having a basic skill set related to geriatrics makes a whole lot of sense to me. And I know some institutions think that way. I know of organizations like that are doing this with primary care, which is also, something that your patient presents, and if they have a primary care need, in the KP system, for example, if it's a surgeon, if it's a radiologist, whoever it is, if you have the information in front of you and this patient has a primary care need, you attend to it. So it's sort of like it's everybody's business because, it's the opportunity to address the patient need. And I think if we brought that same mindset to treating of elderly patients, that everyone who touches them has an opportunity to provide the kind of more general geriatric care, we might be able to address these shortages.
So this is what I'm going to share is a novel thing, I'm sure, especially for you. But one of the things we are doing now is doing more intensive risk stratification based on health determinants and how healthy they are. Obviously, the elder generation typically fall into the higher degree of that. So we are trying to surround them with more services that aren't just me as the provider. So care coordinators, social workers, all that are assigned to a pool of patients specifically in this case geriatric patients, so that they're getting surrounded and enveloped with a whole coordinated care, that it's not dependent on the physician and his or her nurse just to do it. So I think that's one of the things that we're trying to do, is we understand that is a high utilization thing, and those are the people that need the most services. So trying to wrap them a whole care continuum of care around that patient or that family seems to really help take the burden off of the provider, spread some of the love to that geriatric patient, and give them better care. So that's one of the things we're doing at our institution.
Bob,
And I'll just close, and I'll say, perhaps we didn't talk about it too much because there's a whole other panel on older folks there. But I would say that everything we talked about is applicable to older populations. As an aging baby boomer myself, and having spent a lot of time in the VA, I recognize that. And I think our focus has been on sort of people with multiple chronic conditions and how to take care of complex patients, which I think is directly applicable to older patients. So I think we're doing some work on that, and you're right, it's coming. It's going to be big. Mm-hmm.
Well, thank you all. With that, I think we're going to wrap up and move on to the rest.
Thank you, Julie.
Thank you very much.